for presentation today is Clinical Evaluation and Management of Paralytic Lag Ophthalmos, our study.
Louder, please.
Paralytic lag ophthalmos occurs due to weakness of the orbicularis oculi muscle and damage of facial nerve. There is incomplete closure of the eyeball. It's important to determine the cause of facial nerve palsy, as there might be life-threatening conditions like stroke, intracranial mass, or paraneoplastic disease. Other etiologies include infectious disease and idiopathic. The aim of our study was to evaluate clinically and treat the cases of paralytic lag ophthalmos. The period of study was 1 year and total number of cases were 11, and out of which 7 were male patients and 4 were female patients. Regarding the age distribution, 20 to 30 year we got 2 patients, 30 to 40 year 2 patients, 40 to 50 year 3 patients, 50 to 63 and 60 to 71 case. Regarding the cause of lag ophthalmos, idiopathic was 6 cases, associated with cardiovascular diseases 2 cases, and leprosy 3 cases. And the patients presented to us with the complaints like unable to close the eyeball in all the 11 cases, and watering 7 cases, foreign body sensation 4 cases, and red eye 3 cases. We assessed the strength of the orbicularis oculi muscle and corneal sensation was tested. On examination, conjunctival congestion was found in 5 cases. Both conjunctival and ciliary congestion were found in 6 cases. Exposure keratitis in 3 cases. Neurotropic keratitis 1 case. And when we record the visual acuity, 6/6 in 3 cases, 6/9 to 6/24 3 cases, 6/36 to counting finger 3 meter 2 cases, and less than counting finger 3 meter 3 cases. And regarding duration of presentation, within 1 week 4 cases presented to us, and within 4 weeks 5 cases presented to us, and within 4 months 2 cases. All the patients referred to neurology department for evaluation of the facial nerve palsy. Regarding treatment, it varied depending on the ocular surface involvement. Systemic steroid prednisolone acetate was given to 9 cases, and topical antibiotics moxifloxacin and lubricants like carboxymethyl cellulose, sodium hyaluronate given in all the 11 cases. Patients advised for lid closure during sleep. Tarsography was done in 3 cases, and palmaris longus tendon transfer was done in 1 case. So this is the case where lateral tarsography was done. This is another case where also lateral tarsography was done. We waited after giving systemic steroids and giving lubricants and antibiotic eye drops. We waited, and then we did the lateral. When it didn't recovery was not well, we did the lateral tarsography. To conclude, paralytic lag ophthalmos is a common condition. Majority of the cases respond well to systemic steroids, antibiotic eye drop, and artificial tear substitutes like carboxymethyl cellulose and sodium hyaluronate are useful. Voluntary closure of the eyeball during sleep with application of local antibiotic and vitamin A eye ointment was also useful. If persisting after 6 months, tarsography is very helpful. Thank you.
Hi, did you grade the level of lag ophthalmos? Did you grade the level of lag ophthalmos in all the cases and kind of try to assess which cases, did better depending on the amount of lag ophthalmos, and how many cases required tarsography even though the amount of lag ophthalmos was lesser?
Actually, most of the cases, yes, some of the cases, there were very mild degree of lag ophthalmos, which responded excellently to systemic steroid, and when it was slightly moderate, also responded to systemic steroid with topical drops, and when it was severe, it did respond to steroid, and we had to do tarsography.
You mentioned in conclusions that tarsography in cases persisting for 6 months. I think that's too long, because you have to see the sensation also. Sometimes if the sensation is not there and you have that kind of picture, you have to do immediately, because you have to prevent the damage rather than.
Yes, that's true. Most of the cases, actually, the corneal sensation was normal. So the cases we waited
And
Was-
the patients where we have got loss of corneal sensation total plus exposure, we have to do central tarsography rather than the.
Yes, yes, in some of the cases actually.
So, any imaging studies you did on these patients?
Pardon?
Any imaging studies you did, like an MRI brain?
Yes, yes. MRI brain was also done. Actually, we referred all the cases to neurology department because
Yeah.
to evaluate the case, the MRI was done.
So, what were the results in this in these
Actually,
cases?
most of the since all the idiopathic causes, we found that the MRI was normal.
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 Yeah.
Yes.
So that is why when you started steroids.
Yes.
Okay.
You didn't got any case secondary to trauma or something?
Actually, we didn't get a case of secondary to trauma. That is also possible in case facial
That's
palsy,
most
but in
possible.
our study, it was not.
Or
done.
early any case of neoplasm or like that? No.
Neoplasm also we didn't get.
Oh, thank you.
Just not related with this study, but I would just like to add that vitamin A ointment, although it is there in the market now for some time, but now some people are saying it's not very safe because it
Okay.
does cause some photokeratitis. So
Okay.
I don't know. Maybe you have to evaluate this ointment
Okay, another
before
study is to be
giving.
done to
Yeah,
evaluate
yeah,
the
yeah.
effect of vitamin.